Good afternoon, everyone. Today's the topic which is given to me is digital workflow in prosthodontics. So we will be next 50 minutes. I'll be discussing a small aspects of digitalization that has we have adapted on a day-to-day basis in our practice, and few of the things I'll be giving you as a tips for the examination also. So let's start with the presentation. So why we have to adapt to the digitalization is, so over a period of time, the study says the more you have digitalized, we have reduced the treatment timings by 30%. So 30% of treatment timing is very much important, because from 10 hours we have reduced it to the treatment, you have reduced it to 7 hours. So that is a huge timing. Why digitalization is the need of the hour? See, we are being doing a conventional procedures from like many years now. So now in the era of digital world, so we have a few things which have a added advantages over our conventional techniques. What are those added advantages? Are like we have a better data collection and data processing. Okay, so whatever is the intraoral data that we want to collect, we can get it in a better and more accurate manner. Okay, then second one will be a chair side and a lab side time conservation. So how this happens is, so there are no tedious procedures like dual impression what we do in light with the light body and putty. And when it comes to the lab side, see there is when we used to send the cast from one city to the another city or a models, so it used to take a lot of time. So the data transfer through email is such a fast thing that your time conservation happens there. Okay, and the third thing is the more accurate outcome of the processes. Yeah, because the most of the processes with the digital process, what we are doing is either they are printed or they are milled. So the outcome of the processes always becomes uh, a it will be on a superior side. The third would be, sorry, the fourth would be the increased patient satisfaction. So how the patient satisfaction is increased is, once first of all is a better prosthesis, better fit of the prosthesis, which increases the patient satisfaction. Second one is the patient comfort. When you take, see, when we are making an impression, there are a lot of times we might have like patients are like they have a gag reflex, so there is a contamination of the saliva, lot of things that are there in the manual procedures. So that can be like we can reduce them by taking an intraoral scan where we don't even touch any part of the intraoral structures. Okay, and the fifth most the most important thing is your data preservation. So what you had done now, whether it is a pre-op or the post-op data that can be compared with with the final prosthesis, those all things can be preserved for your future references. So the scope of digitalization in prosthodontics, as I told you, it can be divided into two things. The digitalization can be divided into two things. One is how you are digitalizing your clinic or a chair side digitalization. Second one is when you're sending data to the lab, then how the lab is getting digitalized. So there are two aspects of digitalization, so we'll be discussing one by one. So before discussing these things, I want to discuss something about what are the components of digitalization, what are the things, what are the instruments that are there should be there in your clinic to make your clinic or a practice digitalized or a prosthodontics digitalized. Okay, so there will be, when I talk about the chair side or a clinical digitalization, so it would be like it starts from a basic photography. So whenever the patient comes, so you take basic, you don't have initially you don't have a DSLR, so you start with the mobile photography. The patient is there on the chair, you take few pictures of him, intraoral pictures, you show it to him, zoom it and show it to him that you have this problem, that problem. So that makes easier for the us to communicate with the patient and tell them what their disease is exactly. So the photography Initially you go with the mobile photography, then once you like over a period of time you can shift to the DSLR photography. Okay, these two things. After these two things, what we have digitalized in our clinics, our day-to-day practice is the radiographs. So radiographs, like initially we used to have our manual like physical radiographs, where we used to take take a radiograph, then go to the dark room, then develop that. It used to be like very much of time consuming, and the processes and the data what you used to get, if there is some problem during the processing, and then that whole data is gone. So now with the digitalization we have these RVGs and OPGs, which are like we can put it in our clinic. So RVGs, usually you will get the X-ray immediately on your computer within like 2 to 5 seconds. Okay, so then the third one, the most important and the most hot topic in the dentistry nowadays, is the intraoral scanners. Now the intraoral scanners have made the life easy for many people, as to the dentist as well as to the lab technician. Okay, so we will discuss in detail about the intraoral scanners later. Then the another device that which can digitalize our clinic is our lasers. So lasers are very much important for many procedures, because now people want bloodless surgeries. Now they want something which are painless. So lasers plays a much role in those kind of surgeries and the procedures. Okay, then once you have intraoral scanners in your clinic, the 3D printers become must. Okay, otherwise what happens is whenever you have intraoral scanners, you need to print those models also. So when you try to print those models, when you send it to the lab guy will charge you more. So better than that, having a 3D printer in-house will add to a lot of things. That 3D printers, you can give immediate chairside temporization, or you can print your guides in-house. You can do some what do you call it as good kind of temporaries, or even you can give a long-term temporaries with the 3D printers, or you can also give printer a splint or a occlusal therapies. So after those are the basic devices what we spoke. Then when we talk about the advanced devices, that could be, because these are very expensive devices that everyone can't afford it. So but these are the things which will make your clinic or your practice more advanced. These things would be your T-scan, TENS, and EMG. So these three usually these three machines we usually use it for our occlusal corrections, the muscles, and they are being more widely used in a TMJ therapies. Okay, TMJ therapies and the orofacial pain and the craniomandibular dysfunctions. Okay, then the next one would be your implant or a dynamic navigation system, where when what we have planned over a city, that will be, we can real time we can visualize where we are going, whether we have whatever we have planned that is been executed in the patient's mouth or not. We can check it real time. That we will be discussing it again in detail later. And in-house CBCTs. In-house CBCTs is the like one of the most welcomed machine nowadays in a day-to-day practice. But due to its expenses, everyone, like initially everyone can't afford it. But in-house CBCTs, having in-house CBCTs, it is the best diagnostic thing that you can have it in your clinic. Whether it is pre-op implant, post-op implant, the CBCTs would guide you the better things. Then we discussed about our clinic digitalization. Once the clinic digitalization is done, then the data is sent to the lab. So how the lab processes this data again depends on the equipments and the facilities that lab has. So, but basically when you want a complete digitalized process, so the lab should have a digital workflows. So digital workflows, the conventional workflows are something where we do all wax up, then we do a lost wax technique, then we send it to the then the processing of most of the metal happens. But in digital workflow, what happens is most of the things, uh, whenever we have imported the data, that data can be processed on a softwares. So the manual things, they are being done on a software, so the accuracy also increases, and the what you call it as the skills of uh, the technician, which were very crucial to design your prosthesis, can be reduced, because uh, the more thing, these all things will be done by a software. So the softwares which all we use usually are the exocad, the blenders for dental, and the 3Shape. There are a lot of softwares that are there in the market, but usually we are mostly like widely used is a exocad software. So the lab should be well equipped with the exocad or blenders or a 3Shape. Apart from that, it should have a good printers, okay, which maintains the accuracy. Then the lab scanners, see, sometimes what happens, we might not be having a intraoral scanner in the clinic. So what we can do is, we can take the manual impressions, accurate impressions, then send it to the lab. That lab guy, what he will do is, they will scan the model that will be done in a lab. So once the model is scanned, then the same data is processed through the softwares like exocad. Okay, then once that is done, then we have our milling machines. Milling machines will be subtractive. These machines will be subtractive in nature. And we have a DMLS. DMLS, basically they are additive machines. Okay, the printers, the 3D printers of a metal. So if these all things are equipped in a lab, then the digitalization becomes easy. So the process of digitalization includes both the clinic as well as the laboratory procedures to be in a synchronized manner. Okay, let's talk about the photography. As I told you, the digitalization starts with photography. Photography, why the photography is important? See, the photography is when the patient comes in and you have a good DSLR photos, you can, the most easiest part of convincing a patient is show them your cases, show them your previous things. And apart from showing your cases, when the case is ongoing, the initial pre-op and the post-op photographs, whatever is the changes you have done, they can be well observed by the patient and well appreciated by the patient. So the photography becomes very much important for the patient also, and for your comfort also, because once you patient is not there with you all the time. So when you take a good photographs and smiling, whatever the photographic protocols are there, if you follow that and you take those photographs, then whenever the patient is not there, it is easier for you to match the shade, to take the texture, see the texture of his adjacent teeth when you are doing anterior build-ups. And it also helps in checking the like the zenith lines. So these all things you can just visualize over a good photography, where you can match the prosthetic things more naturally. So when it comes to the photography, how it helpful is pre-op and the post-op documentation, detailed visualization of the problem, depth and focus area should be optimal, and selection of the lens is very important. See, why the selection of lens is very important is, see, the lenses will vary. There are hundreds of lenses, okay, in the market. So whenever we are making an intraoral photography, there are specific lens which will take a good intraoral detailed images. So usually what we use is 100 mm macro lens, okay, for the intraoral photography. For extraoral photography, the lighting is important than the lens, but usually we use somewhere around 35 to 45 lenses. They are enough with a good lighting, so for extraoral photography. But for intraoral photography, it should be always a 100 macro lens, okay. And to know, see, you should know your camera better to adjust the values. Okay. But these are few values which I usually do it in my intraoral photography. So for intraoral thing, I will be using a 100 mm macro lens, okay, where I'll be keeping a f value. F value is your depth value, okay. So usually I'll keep it 22 plus. So my macro lens takes it up to 32. So I'll be keeping it up to 32. So that will be my maximum f value. Then the shutter speed I keep it around somewhere around like 125 to 200. ISO for intraoral photography is 100 to 200, and the recommended flash would be our ring flash. So ring flash, it gets attached to your macro lens in the front region, so which gives a better view. So it is only focuses on the intraoral things. Soft light is optional in the intraoral photography. If you don't have it, no need. You can take a good photographs without soft light also. So when it comes to the extraoral photography, the 45 mm lens, as I told you, or the 16 to 35 mm macro lenses are also fine. The f value should be reduced because uh, 8 to 10 would be an ideal f value, because we don't want anything very in depth, because for f value more than 20 or 20 25 or 22, we would be requiring a lot of light sources. So better to keep a f value in between 8 to 12. Then the shutter speed again same 125 to 200, ISO 100 to 200. The you can keep more ISO depending upon your light setup. And for extraoral photography, it I would recommend for a twin flash rather than a ring flash. Twin flash has two flashes, so which gives a better light, and the soft light is must for a extraoral photography. So why photography is important? As I told you, you can see these two images. These are of a same patient. One is taken with blur, one is taken with a camera mobile which was not very good, and the second one is taken with the DSLR. So you can see the changes in these two pictures. So the DSLR photography always makes life easier for convincing a patient. So once the photography is done, so we will be talking about the intraoral scanners. Now, as I told you, the intraoral scanners have become the hot topic in recent days. Why? Because the pricing of the intraoral scanners have reduced. So initially the intraoral scanners, there was no scanner which was coming below like 15 lakhs. So it was difficult for every practitioners to incorporate this intraoral scanning in their day-to-day practice. But now what has happened is the pricing of the scanners has reduced drastically, and that is mainly due to your competition. So there are hundreds of scanners are there in the market now. So we'll just see what are the scanners, why they are being used. Okay. What are the advantages of these intraoral scanners? So first of all is the accuracy. So we have made the messy alginate impressions, then we have made the light body putty impressions. The most difficult part of all these impression techniques is you require a patient cooperation. So in these all things, if the patient has a gag reflex, if the patient has a lot of saliva, if the patient is very sensitive to your movements, and if patient has like is anxious, so these all things can be like eliminated with the intraoral scanners. Along with that, the data which is being occupied by the scanner is much superior than the data what we collect it in our alginate impression or any other impressions. So the most accurate way of collecting the intraoral data. The second one is elevated patients, as I already discussed. The third one is the reduced chair side time, as I already discussed. When we make a light body putty impression, it takes about 8 to 10 minutes to make that impression. And when we have a scanner, we can finish that scanning within 30 seconds to 1 minute. Okay, and fast data transfer to the lab. See, now if my lab is there in Delhi and I'm working in Bangalore, it takes about 3 days to send my model to that Delhi lab. So, but when I have a scanning data which can be sent within 30 seconds to the lab through email, so which is better, we have the faster one. Okay, so the data transfer becomes much faster. So when the data transfer become much faster, your work, that time is reduced. So after that, there is no cross contamination. As I told, whenever we are making impressions, lot of contamination that is collected in the impression trace and impression material, that we, when we transfer, there is lot of contamination is transferred from the clinic to the lab side. So that all been like reduced to zero, and neat and clean procedures, because patient is comfortable, you are not mixing any kind of materials like impression materials, or you're not pouring those casts in your clinic, so your clinic looks more neater and cleaner. So basically, whenever you want to have a scanner, it should have a scanning range in between 14, at least 14 into 14 mm up to 25 into 14 mm. Okay, the scanning field range. Okay, with a scanning depth of at least 10 mm and 14 mm. Okay, so the scanner, whenever you are choosing a scanner, this should be the specification you should be looking for. And the scanning resolution should be at least 25 microns, but optimal scanning resolution, like whatever the scanning resolution should be, like somewhere around 25 or below. And this QR code, whatever I have like shared, this, when if you scan, it will take you to the your article which, from where it has been taken. So in future slides also, whenever you see a QR code, that is the you can scan it and you can read the full article there. Now, what are the types of scanners? The scanners broadly, they are divided like there are 5 types of scanners. One is the optical scanner, which projects a laser light or a white light. Okay. Then we have a 3D laser scanners. We have a photographic technology scanners, mechanical scanners, and a video technology scanners. So, but in whatever scanners we are using in our clinics and in a dentistry, they are laser and a video technology scanners. So they stitch the data and they give it to us as a whole image. Then functions and advantages of intraoral scanners. So as already discussed, so pre and post intraoral documentation, whatever is the procedure we have done before and after, we can document it, and it should give a real-time recording of intraoral procedures. Okay, then also it should record your jaw relation and a bite registration. So for example, if I am undergoing for a full mouth rehabilitation, so if I have a vertical dimension and a centric relation, so what I can do is the same thing can be repeated for the final prosthesis. There is no need to again do the same procedure. Okay, this is helpful in our full mouth implant cases. If the patient has come to you with the deteriorated dentition, so what we can do is, but still maintaining the centric and the vertical height, so we can have a pre-op scan of that and keep it. Then once we place an implant, or once our healing is done, when we are going for a prosthesis, we can just take the impression at that time and merge two data and have a vertical dimension as well as the centric relation, so that one procedure that can be eliminated during the prosthetic phase. Okay, then it should indicate the occlusal clearance post teeth preparation. So once I have done a teeth preparation, so my scanner, when I do upper and lower scan, and when I take a bite of that bite, then it should show me the clearance, that how much I have, because for different as we know that for different prosthesis or different kind of crowns, we need a different clearance, so that would be indicated in the scanners only. So if there is a less clearance, you can do the chair side changes, so that your technician doesn't send you the model telling that there is a less clearance and again increase the clearance, so that all things can be avoided. You can just remove that part from the scanning, then increase the clearance, then again rescan only that area, so you will get the accurate clearance. Then the shade gate, few of the scanners they also take the shades of the teeth. You no need to take again separate shade for the prosthesis, that making it very much accurate in the shade selection. Then easier to store and transfer the digital images between dental office and the laboratory, that already discussed. Immediate evaluation of impressions and partial re-impressions are possible at dentist scale. So as we already discussed that once we make scanning, we can evaluate it there and there then itself. If there are any changes, if we feel that this portion is not been recorded properly, or it has been like there is overlap of something, then we can just take out, delete that only that area and rescan it. Okay. So this is a scanning technique that we should follow. The number one, we go occlusally. Okay, from the number two, we go to the palate, the lingual aspect. Then we come to the buccal aspect. That should be the scanning technique that you should follow. Coming to the lasers, again, the lasers, you know, they are much important in our prosthodontics due to a lot of applications. They can be divided into two things, surgical and a non-surgical. Non-surgical, we are not using much in our day-to-day practices, but yes, surgical, hard tissue and the soft tissue lasers we are using. Then there are like diagnostic lasers, then the low, then we use the level laser therapy and the other things, but non-surgical we are not using much. The surgical one, yes, we are using it in the day-to-day practice. So application when it comes to the lasers, we have gingivectomies and gingivoplasties, crown lengthening, frenectomy, frenotomy, soft tissue countering around the implant. So this the latestly what we are doing, soft tissue countering and all this is much more advanced implantology, where we are like shifting from FP3 FP2 prosthesis to FP1 prosthesis, where the countering of the soft tissue is done, that can be done best with the lasers. Okay, then the decontamination of the implant surfaces. So it can be like before the implant placement you can decontaminate the surfaces. Then the peri-implantitis management. So implants, whenever we have placed an implant and over a period of time that we see that there is lot of peri-implant mucositis and peri-implantitis, the best way to address the peri-implantitis would be the lasers. So how the lasers are used is, we can decontaminate the surface of the laser implant. Then we can even the soft tissue, which we can do a biomodulation of that, which will lead to the reduced inflammation and the infection from the area, that will help the better healing of the soft tissue around the implant. And also it makes a better environment for the tissue on the bone to adapt over the implant. So that's what the photobiomodulation and the laser assisted periodontal therapy, these all things, the same things what I told you already. Then coming to the printers. So we discussed about cameras, then we discussed about intraoral scanners, then we discussed about lasers. Then the another vital part of digital dentistry is our printers. So these printers are very much important in data like digitalization. How usually whatever we do it, whatever we design it, they need to be fabricated, right? So the fabrication can be done to the printers. So printers can be your, usually the printers are your additive things. So whatever the raw material is there, we add it, either we polymerize it later or we add the polymerized material. So printers, there are like we have a wet polymerization, powdered bed fusion, material jetting, material extrusion, sheet lamination and binder jetting. These are the few like types of printers that we have it. But basically we can divide the printers into medical grade printers and industrial grade printers. So industrial grade printers, the accuracy is not that accurate, but the medical grade printers are, yes, they are pretty much accurate. In this, we should know these two things, that is wet polymerization, where we use a stereolithographic printing units we use, that one, and the another one is powder bed fusion, where we print a DMLS crown. So these two things are very important for us being a prosthodontist. So then again, when it again another printing classification is selective laser melt. There is one melting, there is sintering, there is fuse deposition, there is stereolithography, and digital light processing. I'll not go in detail about these things. You can, again, I have put a QR code where you can just scan it and go through these articles. So you should know what are printers. So basically, whatever we feed it to them, they print and give it to us. There are different types where usually the most medical grade printers, what we have a resin. So resin, we can just put, layer by layer it is been added. So once the layer by layer it is added, the same time there is a curing of that resin happening. Okay. And another types of printer would be our metal printing. So that is our DMLS. Okay, this is the direct metal laser sintering. So it is the layer by layer it is added to the of the raw materials. Then I spoke, I told you about the T scans, how the T scans are there in the market now, which helps us to digitalize our practice. Then where these T scans are being used now? So the T scans, basically we are using it for occlusal or orthotic corrections. So instead of using our old fashioned articulating papers, where most of us we might miss the markings on the articulating papers, which needs to be like corrected. But when it comes to the T scan, it gives you a real time dynamic occlusal contacts. Okay, so when it gives a real time dynamic occlusal contacts, you will get to know which teeth is touching first. Okay, and what is the what amount of pressure that it is what amount of load it is having. So it helps to determine the time, force, and area of contact. Okay, so advanced diagnostic aid to determine the occlusal premature contacts and occlusal and disocclusal time. Okay, this is widely we are using that whenever like we have a patient with the TMJ problems, we are checking the occlusal equilibrium, we want to do a occlusal equilibration. This is the T scan is the best thing that we can do it. Okay, then another thing is this T can it is not like we have to use only for a TMJ cases or other complicated procedures. We can use it for day-to-day routine to check high points on you on our crown and bridges also. So it has basically USB sensor handpiece with the sensor mount, then a high resolution sensor foil with embedded connective grid and monitor. So basically there are three components. One is the sensor, one is handpiece, another one is the software with the computer. So what it basically does is there is a flow of current in the T scan. So whenever the teeth touch, that flow is interrupted, then that comes as a high point. Okay. So once the T scan is done, we will be moving to our the most commonly used tool, or which we use it as a day-to-day routine as a radiographic advance, that is our CBCTs. So why the CBCTs are become important are like because they give completely accurate, 100% accurate data, three-dimensional data of the bone. You can they are helping in the diagnostic procedures. They help you to detect the tumors. They help you to do a virtual planning of the implants. There are a lot of things that you can use as a diagnostic aid. So the like the application, when it comes to the application, we have a pre-planning of implant surgery, the virtual surgeries can be done, then tumor detection can be done, and airway visualization can be done. Okay, then when after these things, So till now we discussed about our components or the instruments that are required to do a digitalization of our clinic. Now the main topic, that is the procedures that requires the digitalization. Okay, so till now we discussed about what are the components like photography. Okay, then we had intraoral scanners, then we had lasers, then we had printers, then we had CBCT, so and T scans. These are the things that are modern equipments that are making our clinic digitalized. Now what are the procedures that can be digitalized in our day-to-day routine? So first one is CAD CAM crowns and bridges, DMLSs, fabrication of cast partial dentures with exocad, digital complete dentures, implant virtual planning on CBCT, implant planning for guided surgeries, and the model printings. So these are the like routine procedures that we can completely digitalize in our clinic. So let's see one by one. So what basically we are doing is, so we what we require is, first is data collection. So to do any kind of digital work, you require a data collection. So data collection can be a physical data or a digital data. So as I told you, digital data, what is digital data? We are doing an intraoral scanner, sending it to the lab. That is our digital data. What is physical data? We make an impression, we send it to the lab, and lab guy scans it, then it becomes a, again it becomes a data which is being collected in the clinic labs. So once that is done, then we have a planning and designing, data collection, planning and designing, then a production. Okay, these are the three steps which are common for all digitalized processes. So the data collection can be, as I told you, it can be intraoral, extraoral impression, and a lab scanning. So let's see this video where how the once the data is collected, how we are going to process the data. Okay. So this is an exocad where we want to do a 3/6 crown there. So this is the form. The first form comes, like we have to fill the form where whatever what type of material is required, what type of teeth we are like fabricating, on which teeth we are fabricating, what are the antagonist, what are the adjacent teeth. Once this is done, then we come to the actual exocad where we have to import the data, whatever data we have, like we have got it from the clinic or the lab scanner. So we will be importing both the upper and the lower data. So once the data comes, then we have to orient our data to the scan. So once the orientation is done, so it is we are just checking the any correction that are required in the intraoral scans. So once that is done, the first thing we will be doing is we will be marking the finish lines. So here we are marking the finish lines of the prepared tooth. So basically this video I am showing you the how we fabricate a fully anatomical crown with the help of exocad. So this is intraoral scan that we have got, and we are marking the finish line on a 3/6 teeth. So once the marking is done, check the marking from all the sides. Then once the marking is done, when you do the next, it will show you the path of insertion. If there are any undercuts, that those needs to be taken out. So if there are no undercuts, you can go for the next step. So once this is done, you have to you already marked the adjacent tooth. So you take from a library, you import the whichever anatomy of cap you want or crown you want, you can import that. Once you import, it automatically takes it to the prepared tooth, and once it takes it there, you need to adjust the adjacent contacts and the occlusal contacts. Once these things are adjusted, then it will automatically it will cut your the margins where you have marked the margins. So it shows you everything, which is the buccal side, the lingual side. Once it is done, see, you can see that it is merging with the margins. So once this is done, then you again the minor corrections if you want to do, you can do it, like you can smoothen the surfaces, whichever if you feel that there are any like high points, you can take down the high points from there, and you can see for the marginal like the mesial and the distal contacts. Once all these things are seen, then you can feed it to the printer. You can feed it to the printer, or you can feed it to the milling machine. Okay. So this we just saw the video. It was just a glimpse of how we fabricate a single crowns. So this is all about just importing the scan, physical or a cast. Then if the physical cast is there, it needs to be scanned with the lab scanner. Then filling the order form like on a page one of the software, marking the finish line. Then select the desired anatomy available from the library. Then adjust the anatomy, occlusal contacts, and the mesial and distal contacts. Smoothen the edges. Then send it to the feed it to the milling machine. So what are the advantages of this doing of this is time consuming. The conventional procedures are time consuming, requires lot of hand skills, lot of material dependency, and lot of instruments are required which can be avoided here. Then once we saw about the digital process of our single crown, now we will see how what we do in a removable prosthesis, that is our cast partial dentures. So again the initial phases remains the same, that is data import. Then better to usually in whenever we are doing a cast partial, it is always better to scan a cast or a model then intraoral scan. So basically you can make a manual good impression. Then once you make an impression, do a designing, then that scan that cast, it is better to scan. Then there is a teeth arrangement, then there is a design of a framework, metal framework, then feeding it to the milling or a printing machine, followed by framework trial and acrylization. We'll just see the video how it works exactly. So this is a scanned uh, cast where we have to do a prosthesis or a CPD. So initially we are just visualizing the cast from all the sides. So once that is done, we will be placing first the 1/6 teeth. So you can distal point to the mesial point of the 7. So we have to just mark the distal to the mesial. Once you just mark those 2 points, the teeth will automatically come there. So once this is done, wherever you had whatever planning you had done, you can just add the boundaries to it so that it will be your metal framework boundary. So you have already designed a major connectors, minor connector, the occlusal rest, and the mesial and the distal rest. And once the marking is done, our outline of the metal framework is ready. So once that is done, we will be adding a mesh to the in the edentulous areas, the connectors. You can just refine the margins. You have to relieve few vital structures. So once this is done, this automatically it comes here. The mesh is automatically taken on a software. So this is basically this is a procedure for your CPD. Now the next it will be metal. Once the metal framework completely it is been mark, then it will we have to feed it to the DMLS machine where it will be printing the metal. Yeah, so this is our metal framework which is there inside. Then you have to just smoothen and all inside. So I'll just go to the next slide. Okay, so this is the difference between your manual wax up and your digital wax up. So usually whenever we do a digital wax up, it is more accurate again as less time consuming than the manual wax up. So as I told you, like we will be conserving a lot of time. There are not material dependent and it doesn't require a lot of instruments. So whenever we are doing a digitalizing. So coming to the 3D printers, so usually the complete dentures are not complete as of now. They are not completely digitalized. It requires few manual steps that needs to be done. The manual steps might be like our primary impressions or a secondary impressions or a jaw relation that we need to do it. Then the other processes of printing the dentures and printing the teeth structures that can be done digitally. So these 3D printed digital dentures also they have the same procedures of importing the data and all. So once how they are different is here we mark the borders like and then we mark the anatomical landmarks. Then once that is done, then we do a virtual mounting. Virtual mounting that can be like if you have a pre-op record, so you can have the same vertical dimension and centric jaw relation which you can use it. If you don't have it, then you have to manually do a jaw relation. Then those jaw relation can be scanned either with the lab scanner or a your intraoral scanner, and that will be transferred to the exocad. Then once this is done, we will be doing a prototype trial with the PMMA. Then the final process is milled if everything is fine. So once you import the data, no, so basically it is recommended to do till the jaw relation manually, or you can intraorally scan also with some high-end scanners. But till now you can do manual thing. Then once this jaw relation has come, you have to scan it either in a lab scanner or with the intraoral scan. Then once that is done,
is the model analysis. Tip: you may use the arrows to quickly change the view. The model analysis is the
so
secondary
once that
wizard
is
within the
done,
main
you
wizard. The work
orient the
steps of the
plane.
analysis are presented in a vertical list. This allows you
To
to freely
orient
move
a
between the
plane,
different
what we
steps.
have to do
Note:
is we have
only
to
the
do
activated dark colored step
3-point
icons can be clicked.
marking
All
on
other
the
step icons require a
visual
previous action
prints.
to become accessible and appear highlighted.
So
However, the most simple way is to
when they
follow
are
the
in the
wizard by
same
clicking the
plane,
next
the
button. The model
plane is
analysis is a
getting
very intuitive tool. You
oriented
just need to
like that.
follow the instructions explained by a preview picture. In the first step of the analysis wizard, you need to define the occlusal plane. This can be done with the
So
3-point definition
first
method
we will
or
be
by using the articulated
orienting
plane. In
our
this tutorial, we will only demonstrate the definition with 3
planes.
points. Set the first point on the
So
patient's left
I'm
side, the
first
second point on
marking
the
at the
patient's right
second
side,
molars
and the
on the
third
both
point
the
in the
side, right
center
in
of
the
the
left
arch.
region,
If you
and
have erroneously clicked an
in the
incorrect position,
center
you can
where
drag the
we have
point
the
with the left mouse to the correct
midline
position.
of
Click
the
the Apply button
denture.
to create the plane.
So once
The
this is
sliders to be
done,
used to change the is the model analysis.
so we will be again after this we will
Manually
be
correct the
marking
automatically
a,
detected molar positions. By default, these are placed on the deepest region of the
we
alveolar
have to
ridge. They
mark a
might be
line
adapted manually, and they
exactly
should be
in
placed
the
more or less symmetrical on
center
both
of the
sides.
residual
Proceed to the
alveolar
next
ridge
step. In this step,
on the
the distal
upper
border
and
lines
the
of the last molars will
lower
be defined.
arches. So
Generally,
that
these are
our
located
teeth arrangement comes
22.5 degrees to the
exactly in
intersecting
that
line with the alveolar ridge
even.
line at the molar position. Of course,
So
the border
here you
lines
have
points
to
may be
mark two
adopted manually.
points.
If you have any
So
doubts,
one
use auto
point
detect
is
to get
on
back to the default
the
position.
first
This is an
plane, and
important
this
step
you
for
have
the
to mark the
inclination of the
second
curve of
plane
speed.
on
Proceed to the next
point
step.
on the
In this step, you
elevated
may
plane
correct the
in the
detected
mandible.
alveolar ridge line for the upper arch. Hold the left mouse button to drag the points to the correct positions or endpoints
So
if
once
required.
this
Manually
is
correct the
done,
automatically
you
detected
we have a plane, we have arrangement.
first. By default, they will only be placed if
Then when
possible.
we have both
Second, choose
horizontal and the
always. To force
vertical
the software
plane,
to place
we have
them,
a
click
centric
again on place posteriors to apply the
relation.
change. The third
Then the
option would
teeth
be to never place
arrangement is
them. Since there is
automatically
not
you
enough
can
space in this case to place the last molars, we choose to
feed
let the
it to
software
the
decide. Once the posterior
whatever
tooth set
data
has
we
been
have.
chosen, you may place the anteriors.
So the
To
exocad
verify the tooth
takes
set
up the
selection, check to see if the tooth
all
size and
teeth
form, if available,
arrangements.
match the
So
size
once
and
these
form of the
teeth
patient's
arrangements
jaws.
are
The placement
done,
of the
one
tooth
you
bows
have
and
to
individual
manually
teeth can be
change. If
adjusted
you
in the next
want
step.
to have some correction,
You
you
might
can
use
do
the
the
aesthetic plate
corrections
scan
there.
and the analysis to
Once
verify
this
the
correction
automatic
is
tooth
done,
placement and
you
size
can
selection.
overlap it
For
in
the
the
individual tooth placement, you might hide these visual tools in
existing
the show hide.
occlusal rims to check whether everything is in the plane and everything is like your lip support and the cheek supports are maintained. So once that is done, then you finalize the teeth arrangement. Once that is done, you can take a prototype. You can take a prototype and send it, like try do a trial in a patient's mouth. If you don't want a prototype, then you can directly skip this step and go for a final printing or a milling of a complete denture.
First, by default, they will only be placed.
So this was about the complete denture. Now we will move to the next, which is most important part of our digitalized dentistry is prosthodontist is the surgical guides. The implants we are doing, everyone wants to do an implant. The most accurate way of doing an implant is using a surgical guide, because what happens when you use a surgical guide is the patient comfort is increased. Okay, the second one is the surgical time is reduced. Third one is there is healing period is reduced. Then fourth one is quick procedures. So we don't have to do 3 to 4 hours surgeries for 1 or 2 implants. That we it can, with the surgical guide, the surgery time can be reduced. Okay. So with this, what all you require for a surgical guide, the data. So there is again a collection of data. There is intraoral and a radiological. To fabricate a surgical guide, we require two types of data. One data is your intraoral data. Second data is your radiographic data. So we merge the intraoral and the radiographic data. Then we plan an implant. Then we go for a surgical. This is an overview. So what happens once we have a collection of the data has happened, then we have to go for a prosthetic planning. So because surgical guides are mainly, we are using the surgical guides for a prosthetically driven implant. So prosthesis is planned first. Then once the prosthesis is planned, then we merge the two data, as I told you, the intraoral and the radiological data. Then the next step will be our implant planning. Then we virtually plan an implant on CBCT. or whatever the data which is like there, the collected data. So once that is done, we mark the boundaries. Then once the marking of the boundaries is done, we feed it to the printing. So as I told you, there is an intraoral, extraoral data that the data can be collected as intraoral, extraoral. Extraoral can be your cast, which is scanned in a lab scan, and the even the impression which can be scanned in with the lab scanner. Then what are the steps that are involved in a fabrication of a digital guide is merging of the data, virtual planning of the implant planning, then the guide design and the printing. Okay, this already I have discussed. So first initially this is the patient data that is a photograph, intraoral photograph, and this is our intraoral. We have a intraoral photographs followed by intraoral scan. Okay, once the intraoral scan is there, initially we will start with the prosthetically driven implants we have to place. So we will be planning a prosthesis first. Once the prosthesis planning is done, then we will be going with the implant planning in the same prosthesis. So this is a small video that shows how we do CT scan and all that. I just just skip it. It is the same. anything. So coming to the last part of my presentation, that is our dynamic navigation of dental implants. So this is the most advanced thing that has come recently in the market. That is, so whatever we have planned, how to make sure that we have exactly placed the implant in the same region. So there should be some marker which will tell me I am exactly going in the same place. So that will be with the help of our dynamic navigation. Basically, it works on a, it is like a GPS surgical system, like it's like a GPS, it's a global positioning system. So it has three components. Okay, so one component is your surgical instrument that is compared to your GPS, and the second one is satellite, that is a locator that controls the GPS, and third one is your computer tone, that is your CT images or a CT. So how it works? It basically it works on optical tracking. So it has few things that are you can. There are steps that are happening. Is first is localizer emits the infrared radiations, and the emitted infrared radiations are reflected by the spheres that are attached to the instruments. The instruments, there are spheres which are attached that will reflect the infrared radiation. Then the position of the instrument is correlated with the pre-operative radiograph that which already we have the CT scan, so it will be correlated with that, and with the help of the markers, there are fiducial markers which are there, it will be processed called as a registration. Okay, this is how the process. Okay, so how it works is, see, basically it is the most accurate and it is the most safer method. So basically what happens here is,
Safer, more accurate,
it shows you the
and
exactly where you're
ultimately
going. So
minimally
it has
invasive
few
surgery, which
components
should
in
be the
it.
goal of all
So you
surgery.
can see
We
those
do that in a
markers there.
four-step process:
Okay.
stent,
So usually it's the fabrication
scan,
of the stent.
plan,
Stent is
and
nothing but
place.
the material you
Basically,
have
we
to
do a quick
fiber
stent
material
of a
which the
thermoplastic
patient might be
material that
asked
happens
to
in your
buy.
office.
So it
All
can
of
be
this happens in the
fabricated
office in one
chairside,
day.
and along with
We
that
then
we take
attach a
the CT
CT
scan.
marker to
Okay, with
that,
the
which is
stent
picked
only
up
we
by
take
the
the CT
CT
scan.
scanner.
Okay, this
We load that CT
stent later it is
information
attached to
into our Navident software
instrument like
using
the
this
navigation
memory stick,
system where it helps
and
in
then
our
ultimately we add this black and
calibrating
white
the
tag
instruments. Okay,
in the exact same place that we had the CT.
so what happens is basically this is a
Basically,
demo where
again, we've got
see
a
you have a
stereoscopic
stent
camera
placed in
picking
that
up the patterns on the jaw and relating those to the
you can
pattern
see the
on the
stent here.
handpiece. So
Okay,
I do
then you
one
have to
quick touch
calibrate it. Once you
calibration,
just press it there, it will get calibrated, the tip gets
and now we're ready to
calibrated.
do
So once
surgery.
the tip
As you
gets
can see, we're doing
calibrated, you can
surgery
cross check
directly
whether
on
it
this.
is
One advantage is that
showing
we
the
can do
correct
an
data or not.
accuracy
You
check
can
very
touch one
quickly.
solid
I
surface
just touch a
like on any
structure
tip.
like a tooth
See,
in
you
the
can see
mouth,
the data
and I
here
can see
that
exactly what's
it shows
represented on the
there is a
screen
tip which is touching here.
and
So
see if
that
it
means it
matches
has
what's
been
happening in the
calibrated
mouth.
properly. Once it
Once
is
I do that, I know I
calibrated,
can trust
then
it,
you
and I go ahead with
start with the
surgery.
placement of an
When my
implant,
drill approaches to
whatever it's
within
been
2
planned
millimeters
initially.
of my
So it
planned
shows the
implant
real
surgery,
time
the target comes
moving
up.
of your
The blue cone
drill
represents
into the
my
osteotomy
drill,
place.
and you can see as
So
I
when
tip
you
my
reach
wrist to the right,
the
tip it to
sufficient
the left,
depth,
or rotate it
it
forward,
indicates that
the drill moves. What I really want is I want that blue
when he is
circle
making the
in the center,
movements of his hand,
and
his
it's indicating
calibration
my
is changing,
depth,
so it is
my
so accurate.
position, and my
So once
exact
he reaches,
angulation
you can see
to
these numbers
within
here reducing.
half of a
Once it
millimeter
reaches
of my
like
planned
when
implant
near to 2
procedure.
mm
So you can see
of
this can be extremely
like
minimally invasive.
the apex of the osteotomy, then it will indicate that your it will start beeping. So once you reach 2 mm, it will continuously beep. So it indicates that you have reached the full length of the implant.
Safer, more accurate.
Then the last portion is your photogrammetry. Photogrammetry, it is newly it is been there in a digital dentistry because to overcome the few flaws which were there in the intraoral scanners. So usually intraoral scanners are they are very good for single and one or two implants. When it comes to the planning of like scanning of full mouth, so the most of the intraoral scanners with the for an implant it becomes very difficult to record the full mouth implant cases. So to overcome that disadvantage, they have come up with something called as a photogrammetry. So photogrammetry, what it does is basically we do two things. One, we have a markers we place in a patient's mouth, and we take a extraoral photography. Then we place our scan bodies on the patient, on the implants. Okay, then we do a intraoral scanning. So we have an external photography as well as the intraoral scanning. Then these two data are merged to get a most accurate data outcome. So that is how the photogrammetry works here. Okay, so these two, as I told you, the separate data will be manually merged using a CAD software. With this, I'll conclude my today's presentation. This is a huge topic. I tried my best to cover it within like a limited period of time. I would like to thank my own like institute, Gulbarga, HKE Gulbarga, from where I did my post graduation. Thanks to Moldy sir and all the staff for giving me opportunity for the presentation. And I also would like to thank our Indian Prosthodontic Society Karnataka branch for giving me an opportunity. Thank you all. If anyone has any doubts, they can ask me the questions. Thank you so much.